Yes, yes, thank you. You can
Never,
start.
never, never mind with Fahima. Just go on. I will scroll into the lecture, and you will read them. Read the slides for the audience, please.
Okay. Objectives: case presentations, clinical features of Marfan syndrome, anesthetic implications, review of literature. Case presentations: 35 years old female, previously diagnosed as Marfan syndrome, medical history on beta blockers for rate control, ophthalmic surgery for lens dislocations, 37 weeks gestation, gravida 3 para 2, previous 2 cesarean sections, spinal anesthesia. What do you think? What do we know about Marfan syndrome?
I invite audience to participate, please, in the chat. Or what we all know about Marfan syndrome, whether the clinical features, the pathogenesis, pathology, anything whatsoever.
Every question here in this interactive session, please.
Of course,
It will be for the audience. Yes, please share.
you can share orally if it's more simple. When we say Marfan syndrome, what's the first thing that jumps into our minds? For me, it's a tall individual. I used to think so. Yes, Mustafa said a CT disorder, a tall person, a risk of aortic regurg, mitral regurg. You're completely right. Connective disease, tall, aortic dilatation. Thank you. Aortic regurg, إسراء. Anything else? Aortic aneurysm, lens issue. Thanks, Dr. Buran. Connective tissue, yes, of course, Shaimaa. Okay, so let us introduce to you difficult intubation. Yes, this is one of the nightmares that I was thinking about in the night of the surgery. Hypertension, aortic bicosps, yes, laxity of the ligaments, cardiac lesions, scoliosis. Mohammed, you're definitely right. High arched palate, yes, Riham. Spontaneous pneumothorax, of course. So difficult intubation, high arched palate, Yasmin. Aortic tear, this is our nightmare. Arachnodactyly, yes. Spider-like fingers or hands. Okay, I think this is about all. Mitral prolapse, Dr. Rhonda. Hello, Dr. Rhonda, nice. It's an honor that you're with us, Dr. Rhonda. Hello. Professor Dr. Rhonda Badawi. So I think, Fahima, this is about all. We can proceed with our slides. Let's see what we traditionally knew about Marfan syndrome.
Okay, our colleague, what is Marfan syndrome? Autosomal dominant condition, a mutation in the fibrillin protein 1 gene on chromosome 15 that encodes the protein fibrillin.
This is a very nice photo I found by accident on the web. The acronym of Marfan. It summarizes or groups the most relevant problems of Marfan to us: mitral valve prolapse, aortic dissection, retinal detachment, fibrillin 1 mutation, arachnodactyly, nearsightedness, and scoliosis. يعمل لي
Clinical features of Marfan syndrome. Affected individuals may present with a triad of features: skeletal abnormalities, ocular manifestations, cardiovascular pathology. Skeletal abnormalities like long thin extremities, arachnodactyly, scoliosis. Ocular manifestations lens dislocation, retinal detachment, cardiovascular pathology, aortic media weakness, aortic root dilatation, aortic valve incompetence, mitral valvulopathy.
These are some photos of the common lesions.
On the left, thoracolumbar kyphoscoliosis. On the right, foot deformities.
Valgus, foot, deformed foot. On the left side, we can see hyperextensible joints. On the left, on the right side, the oral cavity with slight retrognathia and an arched palate. Nima?
Lens dislocation.
What is known as ectopia lentis.
Ectopia lentis.
This is an interesting score system, which was known as the Gent nosology. It was revised in 2010 and introduced 7 new criteria to diagnose Marfan syndrome. Apart from the classic triad that we were explaining, this nice score could simplify how to differentiate or to point out Marfan syndrome among other connective tissue diseases. So just one criterion is sufficient for diagnosing Marfan syndrome. Can you go, Fahima?
In absence of a family history, aortic root Z-score equal or more than 2 plus ectopia lentis, or aortic root Z-score more than 2 or equal plus fibrin protein 1 mutation, or aortic root Z-score more than or equal plus systemic score more than 7 points, ectopia lentis and fibrin protein 1 mutation with known aortic pathology.
This is the Z-score calculator obtained online. As we can see here, the calculator integrates the height of the patient, his weight, his age in years, his body surface area, and then the most important thing is the measurement of the aortic root at the sinus of Valsalva sinus in centimeters, and then calculates what is known as the Z-score. So as we can see here, for this particular female patient, she has an aortic root diameter of 3.7 centimeters and her score is 3.05. So if we can apply this score to our patients, you'll probably, of course, we didn't have her measurements, her height and weight, but I guess that it will easily by far pass the two, as we will see later.
In the
presence of family history, the score is much more simpler. Go on, Fahim.
In the presence of a family history, there is one of these three is enough for diagnosis of Marfan syndrome: ectopia lentis, or systemic score more than or equal 7, aortic root Z score more or equal 2.
These are the points for the systemic score, which include all musculoskeletal ocular deformities.
Take-home message for anesthesiologist: there are a number of conditions of connective tissue with a similar phenotype that can be confused with Marfan syndrome. Recently published modifications of the diagnostic criteria facilitate the differentiation of Marfan syndrome from these conditions. Focus has shifted from musculoskeletal signs to cardiovascular and ocular abnormalities.
Surprisingly, by the revised score, the presence of a dilated aorta plus ectopia lentis is now considered sufficient to give an equivocal diagnosis of Marfan syndrome.
Back to our case. Immediate termination of pregnancy was recommended. Patient scheduled for urgent cesarean section. Pre-anesthetic evaluation. Patient was found to have good functional capacity with no dyspnea, orthopnea, or lower limb edema. Airway assessment was satisfactory. Mallampati class 3. Preoperative echocardiographic examination revealed Marfan syndrome with aortic root aneurysm, 62 mm, and severe aortic regurg for surgical consultation.
62 millimeter diameter. Please remember this figure.
So what do you think what would be the ideal anesthetic plan? Regional versus general anesthesia. What do you think and why?
Invite all of you esteemed guests, audience to participate. Let's vote.
Okay.
Which would go for regional and which would go for general anesthesia for such patient. Sophia went for GA. Why, Sophia? Isra Badr went for regional. Why, please? GA, Burhan, GA, Marwa. GA. Oh my goodness. Regional epidural spinal, Shireen. Amgad GA. Sophia aortic dilatation 62. So this is why she wants GA. Combined spinal epidural. Thank you, Karim. Thank you very much. You will regional because of risk of difficult intubation, Dr. Randa. Of course, Dr. Randa, you're an expert of difficult intubation, so I'm sure you will. Nobody can compete. GA, regional, special epidural. Mahmoud Salim, Hilal, combined spinal, regional. I think that the regional votes are the intubation. Combined spinal, regional epidural, regional. Combined spinal epidural, Yasmin Al-Basha, hello. Actually, both are okay. Very nice political opinion, Dr. Burhan. Regional, Masoud Mustafa, Svetlana, combined spinal epidural. Welcome to our team, Svetlana. Mahmoud Abd Gawad, regional epidural Tariq. Al-Husseini Ahmed, GA. 1 GA now. Okay, I think we got our votes. I think that the majority went for epidural or regional. 2 GAs to come. Al-Husseini Ahmed, Mahmoud. They adopt the GA policy. Okay, let us tell you what we did. Or let us first tell you who likes or prefers regional anesthesia, what would be the pros and cons, and who prefers general anesthesia, what would be the pros and cons from the literature point of view. Fahima?
Okay, our colleague.
Yeah.
We forward to all what anesthesia give to this patient, and we would revise the advantages and the disadvantages of regional anesthesia. Advantages: avoids airway manipulations, intubation pressure response, avoids barotrauma, low dose combined spinal epidural anesthesia, allows titration of level of anesthesia. Disadvantages: technically difficult scoliosis, corrective surgery, difficult resuscitation, sympathectomy.
It would result in sympathectomy if not controlled with drugs. Of course, regional anesthesia could result in systemic vasodilatation, of course, pooling.
General anesthesia advantages: if acute dissection occurs, airway is protected, possible immediate cardiac surgery, inhalation agents may decrease cardiac ejection force and decrease aortic dissection risk. Disadvantages: risk of hypertensive response to intubation, failed intubation due to difficult airway, aspiration risks. Cesarean section plus general anesthesia equal high risk for awareness, hyperdynamic cardiovascular responses, barotrauma, cystic lung due to some patients with cystic lung.
Elastic weakness and cystic lung degenerations.
Back to our case. Combined spinal and epidural anesthesia was chosen as Plan A for anesthesia. 2 wide peripheral cannula were inserted plus a Stossel gauge cannula in external jugular vein, arterial cannulation of left radial artery, basic monitors were attached ECG, non-invasive blood pressure, pulse oximeter, heart rate, 80, arterial blood pressure 124 over 60 millimercury, oxygen saturation 99%.
On room air.
500 millicrystalline solution was administered colloid. Epidural catheter was successfully inserted at L2 and L3 space. Total volume of 2.5 milli, 2 milli hyperbaric bupivacaine plus 25 milli mercury fentanyl for the subarachnoid block. Spinal
25.
anesthesia failed to achieve adequate block.
Everything was very smooth, but effectively spinal anesthesia didn't achieve adequate block.
Loading dose of isobaric bupivacaine 0.5%, 15 milli plus lidocaine 2%, 5 milli were given in the epidural catheter. However, epidural anesthesia was unsuccessful as well.
Very sad.
So what do you think? Why did regional anesthesia fail?
Again, those who are advocating regional anesthesia, could you share with us what's your opinion, what went wrong? Our audience, please share with us what went wrong.
Yes, scoliosis.
Karina, there was scoliosis. I can't remember if she was scoliotic or not, but the technique, the steps of the spinal were very smooth. We could receive CSF smoothly. Epidural loss of resistance was very well appreciated during epidural anesthesia. The catheter was introduced smoothly. Drug injection was smooth. No, it was not difficult due to deformities. Everything went smoothly. مش كده فاهمة؟ They said they said it was very, very smooth. Nothing. Yes, total fail.
Total fail, yes.
Yes, total fail. Trabeculation maybe low level. Risks of spontaneous pneumothorax, epidural space not totally connected as part of the syndrome. Maybe, I don't know. Abnormal anatomy, we can't guarantee, except with MRI. Dr. Nisreen Rifai, of course. Dural ectasia, thank you, Safia. Dural ectasia, Dr. Tariq, of course. Thank you, dearest Professor, Dr. Tariq Abdelbar. Resistance to local anesthetic, it's not actually a resistance. You will see it's ineffectiveness resistance. Yeah, we will see on the next slide why did this regional anesthetic techniques fail. Although we have very skilled teams, we used isobaric, we used hyperbaric for the spinal and isobaric for the epidural, yes. Dr. Burhan, we used the standard hyperbaric with fentanyl, 2.5 milliliters total, hyperbaric for fentanyl, and 1020 isobaric for epidural. Yes, of course, Dr. Randa, connective tissue adds to the difficulty to find the space, but we found the space and we injected with no problems, but we got no block. Sometimes there is problem with the drugs. I don't think so. On that day, the drugs worked well with other. Of course, I agree, especially in Egypt, we have bad storage conditions, but no, for this day, everything was well with the drugs. Yes, she had a previous successful subarachnoid. What do you mean, Mahmoud? We are experts. Yasmin, septations within epidural space, maybe. Is it ectasia? We don't have an MRI available. Epidural septal, Dr. Randa, maybe Dr. Randa. We don't have epidural, and we didn't use ultrasound. I think we should learn how to use ultrasound to detect the epidural space and visualize it. I still have to learn this. Supradural, we can't tell, maybe. But the subarachnoid as well didn't work. Tall patient, she is tall, but we should have some degree of block. We didn't have any block. Maybe a little tingling in her toes or up to her ankle, something like this, but no solid, robust block. No. A tall patient would supposed to have something like a saddle, something like a level of مثلا L8, L10 block, but this didn't happen in this patient. Okay, so let's see what went wrong. Now we will introduce Dr. Alia to discuss with us the dural ectasia. This was something new to me. I didn't know what was meant by dural ectasia. I read it the night before surgery, but I said we have to take our chance. Yeah, Dr. Alia.
Hello,
ممكن
everybody.
الفيديو بتاعك يسرع عليه؟
Yeah, there's something called dural ectasia. Up to 50% of the spinal anesthetic given to Marfan women are inadequate, even when larger than average local anesthetic doses are used. Weakened elastin elements within the connective tissue promote expansion of the lumbosacral dural sac. An enlarged volume of CSF is proposed to be the main causative factor in failed spinal anesthesia in Marfan syndrome. Increased CSF volume reduce block height and cause faster two-segment regression time. The postulated mechanism are dilution and sequestration of local anesthetic into ectatic cyst, cephalid drug spread. The image show 3 grades of dural ectasia, grade 1 mild and moderate and severe grade 3. There's a case report published in International Journal of Obstetric Anesthesia 2080, titled as Successful Spinal Anesthesia for Cesarean Section in Patient with Marfan Syndrome Complicated by Dural Ectasia. It described 17 years old female with Marfan Syndrome with her second pregnancy, admitted for elective section at 37 weeks gestation. She has 44 millimeter aortic root dilatation and borderline mitral valve prolapse. The author postulated that inconsistent intrathecal distribution might be overcome by application of warmed isobaric provocaine in a seated patient, injected as far as possible away from diluting effect of ectatic dural sac. The image on the right.
Okay, Alia, go on.
The image on the right side show T2 sagittal MRI of patient lumbosacral spine with dural ectasia and bony scalloping small black arrows and conus medullaris indicated by large white arrow at the T12L1 level.
So here they visualize the vertebral column and spinal cord, located the conus medullaris, the end of the spinal cord or the conus medullaris, as we can see with the white arrow. They also found the dural ectasia. It's still in the early phases. There's only some bending in the posterior border of the vertebral bodies. So they postulated that if they can put or use isobaric bupivacaine as far as possible from the ectatic dural sac and keep the patient seated for some time, they might succeed.
2 milliliter isobaric 0.5% bupivacaine plus routine opioid to a total volume, warmed at 37 degrees Celsius immediately prior to injection at the level of L1, L2 interspace. Bilateral sensory block T4 was confirmed at 5 minutes post-intrathecal injection.
The right, we can see the apparatus that they invented or they used. They used a 500 milliliter bag of saline wrapped in some. They heated the bag and wrapped and connected an IV line, which was wrapped around the syringe and infused the warm saline around the syringe to keep it warm during injection.
In conclusion to this case report, a warmed injected of hypobaric provocaine, fentanyl, and morphine administered with the patient in seated position and the maintenance of that position for 5 minutes post-injection produced a functional neuroaxial block.
By the way, we kept our patient sitting for some time, but it didn't work. Fahima?
Back to our case. Induction of general anesthesia plan B was conducted with 2 mg midazolam, 150 mg propofol, 50 mg atrachlorium, smooth tracheal intubation of 7 mm cuffed intratracheal tube. Anesthesia was maintained by sevoflurane in 50% oxygen. Patient was intubated uneventfully, hemodynamically stable, heart rate 75, arterial blood pressure 100/60 millimeter, oxygen saturation 99%. A viable healthy newborn was delivered. Then naloxone 7 mg was given. Estimated blood loss around 700 millimeters. At the end of surgery, the patient was fully reversed from muscle relaxation. Patient recovered fully conscious, hemodynamically stable, heart rate 77, arterial blood pressure 110/70, pain-free.
All through the operation, her blood pressure remained in this range, maybe a little lower, I think due to the effect of the regional somehow. And we used small titrated shots of ephedrine to keep it around 110 or 120/70. She was never hypertensive or tachycardic, not before surgery, not before intubation, not during intubation, and not even after extubation.
Patient was transferred to PACU. 10 minutes later, patient become pale, hypotensive, blood pressure around 70/40, and confused. Colloid resuscitations and 30 mg ephedrine failed to improve arterial blood pressure. Immediate transfer to the operation room. Patient became pulseless and unresponsiveness. Cardiopulmonary resuscitation started. Endotracheal tube inserted. Defibrillator attached. Asystole. 2-minute chest compressions with adrenaline 1 mg, alternating every other cycle 3 to 5 minutes. Post-arrest CBC was done. Hemoglobin 8 gram per deciliter. Serial EPGs severe metabolic acidosis. Normal capillary blood glucose. Transthoracic echo was used to exclude reversible causes of cardiac arrest. The 4 H's and the 4 T's that Dr. May mentioned in her lecture.
We used
was excluded.
We used the abdominal probe of the echo machine, and this was the only probe available. We could look at the anterior quadrants, the 4 anterior quadrants of the lungs, looking for tension pneumothorax. However, on the left side, by the 2D mode, there were the A lines and a few B lines. Maybe you can't see them here, but we can see them in the video. So by the 2D mode, by the M mode, we illustrated the seashore sign. And as you can see here, the pleural line, the bright line in the middle of the screen is moving. It's sometimes called the ant line. There are a few laser-like hyperechoic lines extending from this line to the end of the screen, which means that the pleura is sliding. There is no air between the two pleural layers. So tension pneumothorax is excluded. However, we performed fast examination to exclude, together with the obstetricians, the intra-abdominal and pelvic bleeding. So as we can see in the right upper quadrant, in the Morrison pouch, in the right upper quadrant, there were no fluid collection, whether perihepatic or perinephric. In the left upper quadrant as well, perisplenic and perinephric, there were no fluid collection. In the abdomen, it was okay. In the pelvis, it was okay. However, surprisingly or sadly, in the subcostal cardiac view, we could see a hypoechoic shadow encircling the heart, suggesting pericardial effusion.
Ultrasound cardiosynthesis was done. and aspiration of
By the
170
cardiothoracic, sorry, Fahima, ultrasound pericardiocentesis was done by the cardiothoracic. I don't remember he was the resident or the assistant lecturer, but he came and confirmed pericardial fluid collection with us and inserted 20 cc's syringe and started aspirating a total of 170 milliliters of blood.
3 bagged RBCs plus calcium chloride were administered. Cardiopulmonary resuscitation continued for 60 minutes with no return of spontaneous circulation. So, what do you think the pathology of this condition?
Would some of our esteemed audience share their experience or of what went wrong? Or how did this patient dissect? Yes. Dr. Randa, I can see you mentioning that tracheum was not a good choice. I totally agree, but rocuronium is not always available in the theater. There are very limited supply. Of course, we should have asked for it, but intubation went well. There was no problem with the intubation. Yes, Omnia, she dissected. The question, why? This is what we will see now. Maybe sudden relief of the gravid uterus. This is what any sensible person would think, yeah. But lots of gossip were going around. It must have been because of the anesthesia. She must have coughed. She must have strained. Blah blah blah. Nothing of this really happened. The patient had a very smooth recovery. She was awake. She was pain-free in the recovery room. She was talking with us. 72, it was 62, I think, or 63 aortic root. Dr. Mustafa is indication for intervention in Marfan, may be accepted for other cases. You're totally right. This is what we will see. This is what all literature agreed upon. Does anyone else have any point of view regarding this case? Sorry.
Alia?
Okay, we can introduce Dr. Alia again to search literature with us. Did they use Methergine?
No.
They didn't use Methergine. Babel. It should be done in cardiothoracic or you're completely right, Dr. Nesreen. I don't know if this is feasible or not. I didn't think of this before, yeah. I think Mustafa, I think preoperative EVAR may be a choice. Okay, let's search literature and find out the core issue for this patient. Dr. Alia?
Hello back. A paper published in Journal of American College of Cardiology 2021 titled Pregnancy-Related Aortic Complication in Women with Marfan Syndrome. A single center experience of 169 Marfan Syndrome women. It concludes that pregnancy-related type A dissection only occurred in patients unaware of their diagnosis. Type B dissection remain unpredictable complication.
Of course, you all must know that the aortic dissection type A is the one that involves the aortic root or the ascending aorta, and type B is the one that includes the abdominal aorta, which is less serious.
Also, a paper published in American Heart Association 2016 titled Aortic Complication Associated with Pregnancy in Marfan Syndrome, the NHLBI National Registry of Genetically Triggered Thoracic Aortic Aneurysm and Cardiovascular Condition, stated that pregnancy in women with Marfan Syndrome is associated with an 8-fold increased aortic dissection risk, both type A and B, particularly in postpartum period. Cardiac checkup with echocardiographic assessment of the aortic root and ascending aorta before planned pregnancy or during unplanned pregnancy is recommended. The European Society of Cardiology has a paper published titled Cardiovascular Disease.
Practice guidelines. Sorry, Aliya. These are the clinical practice guidelines 2010 of the European Society of Echocardiography of Cardiology, stratifying the maternal risk of mortality and morbidity with cardiovascular disease during pregnancy. You can see here the marfan with aorta more than 45 millimeter diameter stands as an independent risk of high mortality and severe morbidity in this patient population.
In 2030, Journal of Anesthesia Analgesia, a paper titled Marfan Syndrome During Pregnancy, Anesthetic Management of Delivery in 16 Consecutive Patients. This is a retrospective medical record review focusing on the anesthetic management of delivery of all parturient with Marfan syndrome, followed at Bechet Hospital, the French referral center for all Marfan syndrome patients over a 6-year period. A pregnancy may accelerate aortic root dilatation, connective tissue weakness, and increase aortic stress due to increased cardiac output. Pregnancy-induced increased cardiac output reach a maximum immediately after delivery. Labor pain, autotransfusion secondary to uterine contraction. Pregnancy and delivery expose patients with Marfan syndrome to increased risk of life-threatening dissection, especially when the aortic root diameter is more than 40 millimeter. Beta blocker therapy is the cornerstone of Marfan syndrome management. In non-pregnant patients, beta blocker therapy has been demonstrated to slow the growth of the aortic root, significantly reduce the incidence of aortic regurgitation and aortic dissection, cardiovascular surgery, and congestive heart failure and death. Current guidelines suggest that beta blocker therapy should be instituted at the beginning of the pregnancy if the patient is not already taking this therapy, maintained throughout pregnancy. If the patient or if the female present preconception, a history of aortic root dissection or aortic valve replacement with mechanic prosthesis or aortic root diameter more than 45 millimeter, we should advise her against pregnancy. But if aortic root diameter is 40 up to 45 millimeter, case by case basis recommendation against pregnancy.
I'd like to attention that this patient presented to the OB/GYN department at 37 weeks of gestation. They hadn't done any antenatal care for her. She came in her late pregnancy asking to deliver her baby in the Qasr Al Aini hospital and acknowledging the risk.
Post-conception. If aortic root diameter is more than 45 millimeter, terminate pregnancy. Beta blocker therapy should be titrated to reduce resting heart rate by more than or equal 20% and to continue intrapartum. Echocardiography at the beginning of the pregnancy and at the end of the first and second trimester, and each month during the third trimester. Mode of delivery should be decided at a multidisciplinary meeting of obstetrician, cardiologist, and anesthesiologist. The decision is based on patient history, reference, and fetal growth and progression of aortic root diameter, repeated echo exam. Vaginal delivery is allowed if aortic root is less than 40 millimeter or 40 millimeter up to 45 millimeter with epidural catheter. Limit the second stage expulsive effort. Indication of elective cesarean section, aortic root diameter more than 45 millimeter, progressive increase of aortic root diameter, history of aortic repair for period dissection, severe fetal growth retardation or maternal preference. If emergent cesarean section due to aortic root diameter more than 45 millimeter or developing aortic dissection should be followed by immediate aortic repair in the same setting. Recommendation: maintenance of hemodynamic control during anesthesia for CS is way more important than the anesthesia technique itself. There is no evidence that one anesthetic technique is better than another. General anesthesia with opioid or titrated combined spinal epidural.
This is a site for, especially for the anesthesia or the orphan anesthesia, or an online site for that offers recommendations for anesthesia of patients with Marfan syndrome. They recommended necessary additional diagnostic procedures preoperatively. اتفضلي عليها.
Echocardiography or cardiac MRI, significant dilatation of aortic root should be referred to cardiothoracic surgeon for evaluation of aortic root replacement prior to elective surgery. ECG if show left ventricle dilatation may predispose to alternation of repolarization and fatal ventricular arrhythmia. Aortic root diameter more than 4 cm measured at Valsalva sinus level or history of aortic dissection should deliver in a center where cardiovascular surgery is available. The 2010 American Colleague of Cardiology and the American Heart Association and the American Association for Thoracic Surgery guidelines recommend elective operation for Marfan syndrome patient at an external diameter of more than or equal 5 cm to avoid acute dissection or rupture. Indication for repair at an external diameter less than 5 cm, rapid growth more than 5 millimeter per year, family history of aortic dissection at a diameter less than 5 cm, or presence of progressive aortic regurg. Prophylaxis against infective endocarditis is not required unless there is a mechanical valve. Chest X-ray should be ordered preoperatively. History of spontaneous pneumothorax. Patients with severe scoliosis should undergo pulmonary function test to evaluate the extent of restrictive lung disease. A particular preparation for airway management, they anticipated to have a high arched palate with crowded teeth, may make visualization of the larynx during direct laryngoscopy difficult. Clinically symptomatic cases of atlantoaxial dislocation in this patient are rarely reported in literature, and screening radiograph of cervical spine for patients with Marfan syndrome undergoing general anesthesia are not routinely recommended. Patients at increased risk of developing pneumothorax, which should be kept in mind during positive pressure ventilation. Excessive traction of laryngoscopy should be avoided to prevent temporomandibular joint dislocation. Cardiovascular response during laryngoscopy should be blunted pharmacologically. Any question?
So our take-home message, Ali, we will keep questions to the end of the lecture.
Okay. The presence of dilated aorta plus ectopia lentis is now sufficient to give an equivocal diagnosis of Marfan syndrome. Beta blocker therapy is the cornerstone of Marfan syndrome management. Pregnancy with Marfan syndrome is associated with 8-fold increase in risk of aortic dissection, type A or type B, particularly in postpartum period. Mode of delivery should be decided at a multidisciplinary meeting. Maintenance of hemodynamic control during anesthesia of CS is more important than the anesthesia technique itself. There is no evidence that one anesthetic technique is better than another. General anesthesia with opioid or titrated combined spinal epidural. Elective operation for Marfan syndrome patient at an external aortic diameter of more than or equal 5 cm to avoid acute dissection or rupture.
Thank you very much.
Thank you very much, Dr. May and Dr. Alia and Dr. Fahima. And thank you again for the management and for the interactive session. And we are having now 5 minutes, or we can make it even 7 minutes. Yeah, for questions, please.
Thank you, Dr. Sana, for your appraisal. Thank you very much. I agree with you that using ultrasonography was very, very helpful. Muhammad Magdi Gaber was asking, why didn't we give opioids in the induction to decrease pressure response, and it could make difference to decrease incidence of dissection? Well, as we all know, our concern during pregnancy, during cesarean section, is the depression, respiratory depression of the fetus. So we usually reserve opioids until delivery of the fetus, and this is what we did. During induction, the patient was already on beta blockers, and she was in tachycardic. We used Dormicum or midazolam together with 150 milliliters of propofol. Dr. Osmat pointed out when we were revising the session that the patient might have benefited from xylocaine. I totally agree. However, luckily, intubation wasn't stressful, and her blood pressure remained on the hypotensive side during surgery. Is the key point in this challenging case that I personally didn't recognize because I hadn't have enough time to prepare, and this is an important point that we want to discuss with the obstetricians, that such serious cases should be handed to us at least 1 week before operation. You can't just introduce such case at 5 p.m. for me and expect me to know everything about it in just 3 to 4 hours. So if we conclude from this session that whenever we have a Marfan syndrome undergoing any surgery whatsoever, we should look at his aortic root diameter, and the aortic root diameter in this patient is huge. The wall is very, very thin. As I was telling my colleagues, if this patient sneezed while she was walking, she might have died. So as Yasmin mentioned, maybe only the evolutionary changes of the uterus would have increased the shear forces over the aorta. Of course, intubation, pressure response of intubation and extubation must contribute. And this is why I chose, together with my colleague, to give her a combined spinal epidural, because I was very aware of the pressure response and I wanted to avert it by any means. I didn't, I hope that it would work, and as the previous 2 spinal anesthesia that she had, but obviously, her elastine was going very, very weak by age because her aorta is huge. Of course, she has no antepartum records of progression of aortic root dilatation, which is another challenge. So I think this is the key point. If we had all, and very ironically, that the cardiologists and the cardiothoracics who saw this patient before surgery, none of them pointed out that we should repair the aortic root or perform it in the cardiothoracic department or anything like this. So this is, I think, this is the key point.
May I have a
Dr.
comment?
Actually, yes, okay. I will just give a comment, Dr. Saad. Okay, actually, the team didn't find a time really to arrange if she can deliver in the cardiothoracic surgery section. So after delivery of the baby, immediate aortoplasty would be done for her, because she presented like maybe less than 1 day only before the surgery. And the decision by the cardiologist was to terminate pregnancy immediately. Why she took 2 spinal before and it was working with her? Maybe the ectasia and other things and the elastine was not that damaged as the last pregnancy and last cesarean section, because her condition is progressive. Again, when she took these 2 spinal and 2 cesarean deliveries before, maybe again the aortic dilatation was not that huge. So the thing or the take-home message, as Dr. May said, يعني, and Dr. Nesreen shared also, if we have a time for next patient with this grave pathology, we maybe the best thing is really to arrange her to deliver in a cardiothoracic theater with all the surgeons and all the equipment available to take her immediately after delivery of the baby and closure of the uterus and ending cesarean to make for her the correct aortoplasty. Okay, you can go.
An interesting question in the chat box here from Dr. Mohammed Mustafa. Is beta blocker going to increase aortic regurgitation? Although it might increase the regurgent fraction, but definitely decreasing the heart rate and the force of contraction will decrease the shear forces, the friction of the blood flow and the turbulence of the blood flow with the walls of the aorta, which is far more important. If you increase the volume of fluid inside a container slowly, you wouldn't expect it to rupture. But if there is a lot of turbulence and shear forces in a weak wall, of course it will crack. Yasmin Al-Basha, Dr. Yasmin Basha, for the future, would you recommend this case to be done in the cardiothoracic theater? Of course, we should ask and arrange if this is possible or not, if they would repair such case or not. We should prioritize, are we going to rescue the mother? And I mean, if we are going to target to repair the aorta and move to a heart-lung machine and compromise the fetal circulation before extracting the baby in order not to involute the uterus, or to extract the baby and just decide that this is a mortality case, something that the multidisciplinary team should discuss together with the patient. Of course, the patient knew that she was a mortality case, and they were sadly very accepting this before surgery. But we have to move forward to multidisciplinary care of patients. This is very important.
Can I ask you something, Dr. May, or all of our colleagues also, they can share? What do we think the most leading factor for the dissection of the aorta and the following cardiac tamponade? What do you think? Because we ask if she sneezes, if she coughs, if there is pain in the post-operative period, if any increase in the blood pressure or any change in the vital signs during intubation, extubation, and there was nothing of all that. So what do you think happened in the PACU? Let's make a brainstorming led to the dissection of the aorta. Anyone can share, even in writing. What do you think, Dr. Nesreen?
Sorry, can you repeat the question, please?
Yeah, I mean,
I was
now,
preparing
listen, the patient came to the PACU, our post-anesthetic care unit. She was calm, awake, fully awake, pain-free, and vitally stable. She did not cough or sneeze. She was completely stable. And 10 minutes later, she developed the full dissection of the aortic valve with the cardiac tamponade. So, like a brainstorming, what do you think has happened to lead to that?
I think it was mainly the evolution of uterus, which pushes up to 30% of the circulation back to the heart. So it increases the preload.
Yes, I think this is my opinion too, because thanks to our anesthesia team, that the anesthetic management pre and post and even after the event and intraoperative, it was excellent. They used all the available tools. Immediate ultrasound and echo was done for her using the curved probe of the ultrasound machine of the OB-GYN theater. Cardiocentesis was done. Everything was okay. But as we said, it's a very, very risky patient that should not even, if she had any antenatal care, she would be advised not to have a pregnancy for the third time. So I think it's...
Sorry, Dr. Abdelbar likes to comment. Please do.
Yes, please.
Evening. You mentioned that you catheterized or you inserted a cannula into the radial artery, right?
Yes.
You hear me?
Yes, yeah, Doctor.
Yeah. Yeah.
Okay. The radial artery was cannulated, right?
Yes.
Yeah.
Was it attached to the monitor to monitor B2B?
No, it wasn't. Because I'll tell you why, Dr. Tariq, frankly. We cannulated the radial artery يعني in the middle of the يعني after induction and intubation and inserting the external jugular. And as you know, sir, these the domes and the cables, it's very difficult to take them out and obtain them. So by the time we were يعني starting to prepare the invasive arterial monitoring, we were ending surgery. It was a very uneventful surgery. It took something like 1.5 hours. So we didn't manage to get it connected. I personally went into the room several times and I found her okay, so I didn't bother to ask to put to connect the transducer. I can't remember if this room has a compatible cable or not, because not all
Can I
rooms
say
have
that,
it.
Dr. Amali, the non-invasive blood pressure monitor, your Dynamap, was measuring every 3 or 5 minutes.
5.
يعني I mean it was stable even يعني yeah.
Yes, Doctor. Yes, during the regional anesthesia, يعني almost first
Continuously monitoring the patient. Yeah.
every few minutes. Once it failed to attain a sensory level and we moved to general anesthesia, it was switched to every 5 minutes. So the patient has a stable heart rate, a stable blood pressure, blood loss was
I think, Dr. Amali
acceptable.
and Dr. Tariq, I really think if there is, you have a good point, of course, because the invasive arterial blood pressure measurement will give you a second-to-second changes. But I think if we had a grave change that would let us suspect that this was the cause of the aortic dissection, it will not stay like for 1 or 2 minutes, because the frequent reading of the Dynamap also gave us a continuous monitor that she was in a stable vital signs or a very, very minimal vibrations up and down from the baseline readings. So I think this was not the cause, or even if like that, it could maybe happen intraoperatively. But what happened was post-operative, and like 10 to 15 minutes. Yeah, I mean, if she was already awake, extubated, and then go to the PACU, this will take like transferring the patient from the OR table to her bed and moving to the PACU. This would take 10 minutes. And then after 10 more minutes from arriving to the PACU, the event happens. So this is actually 20 minutes after extubating the patient, at least 20 minutes. So this means that the event or what had happened in the post-op, not in the intra-op.
Can I give a comment, please?
Yes, please.
Okay. Reading the blood pressure every 5 minutes, this are missed at least 350 readings. Okay? And what I want to say in this critically ill patients, monitoring of the blood pressure invasively, you have a B2B reading in front of you. Number 2, what I can make to reduce the pressure response to extubation is just after the closure of the peritoneum. Now the lady this is a surface surgery after. So I can extubate, I can get out the endotracheal tube and insert a laryngeal mask airway. So the awakening will be much smoother than the awakening from an inserted endotracheal tube. Number 3, I have to keep an eye on the blood pressure throughout the patient stay, either in the OR or in the recovery, and while transferring the patient from the recovery to the intensive care unit. Because this is not a case that's to be left with the nurse or left unattended. So this
Ironically, Dr. Tariq, ironically, we were all around her in the recovery room. Me, Dr. Yasmin, the second assistant professor of the day, Dr. Nashwa Zayed, Dr. Marianne, and I think one or two residents, we were all in the recovery room around the patient, and she was talking to us. Suddenly, while we were standing like this, I started to notice that she has become confused. She stopped talking.
By the way, I'm not accusing. I'm just
Yes, I'm just being emotional about this case. No,
to make the outcome
yes,
probably better in the future cases. This
I
is
totally.
Yes, excellent.
only my
Of course,
concern.
Dr. Tariq.
If
Yes.
sneezing, probably the patient sneezed or coughed, or I mean, it can happen from secretions in her larynx. I mean,
So I'm using sneezing as a figure of speech. I mean that she has a very, very, very thin aorta, so that if anything just tickles this wall, it will rupture. We should have acknowledged this, all of us.
I'm sure
Sorry?
I'm sure that this happened. I mean, after her transfer to the recovery, that's
Yes.
sure. And because the rupture is just instantaneous. That's but how to improve the outcome is just to keep an eye on keeping her blood pressure. I mean, on the low normal. I mean, her blood pressure should not exceed 95 millimeter of mercury systolic, and the mean pressure of 65, 70 maximum. That's perfect for her. And this can only be achieved by a beat-to-beat monitoring of her blood pressure.
I totally agree with you, sir.
Totally agree with you, Dr. Tariq. Of course, this is take-home messages. Yes.
She should have monitor for the depth of anesthesia.
So probably with the we can discuss these things and in the OR as regards the domes, everything related to the arterial line. So
no, Dr. Tariq, the laryngeal masks. We have a tragedy with the laryngeal masks.
Anyway, I mean, if you extubated the patient, I can comment on that one, which is, I think, your second point, Dr. Tariq, about removing the tube earlier and continue with the LMA. I think the risk of extubation is there anyway. I mean, if she finished surgery or not yet, she will be eventually extubated at the end.
No, extubation when either the patient is under light anesthesia or fully awake is totally different from a patient who is under anesthesia. You can give a shot of 5 mL of propofol prior to extubation. You can give a shot of 50 or even 100 mic of fentanyl before extubation, 3 minutes before extubation, and you can always do this. I mean,
but I will ask you something. Yani, do you trust the laryngeal mask in a potentially, all cesarean section is like a potentially full stomach?
After the delivery,
yeah,
no more. I mean, her uterus. The moment the surgeon closes the uterus, it's about 25% of the size at full term. So,
Wallahi, Dr. Tariq, you're very experienced and brave anesthesiologist, but me myself, in my practice, I couldn't risk it. Putting an LMA in cesarean section.
This is elective. This is elective. The patient has got, I don't know whether she got something antibiotics. The baby is out. The uterus is back to normal or near normal, and it's a surface surgery after the closure of the peritoneum. So she's still under deep anesthesia. I mean, she's fully anesthetized under effects of analgesia. Extubation will not do any harm for her, and reinsertion of the particularly and undermining the particularly that intubation was easy. There was no problem with the intubation. So
Yes.
I mean, even if you are not happy with the laryngeal mask, which I doubt so much, then you can reinsert the endotracheal tube under fully relaxed anesthetized patient.
You know, Dr. Tariq and Dr. May and Dr. Nasreen and all the colleagues, I think what really helped her for smooth intubation and smooth extubation is that she was under beta blockers. This would really have diminished or completely, stopped the pressure responses to intubation and extubation. That was her luck. Really, it's her luck. But anyway, these are valuable comments from all the colleagues, and I think we took 1 hour in this session.
I
Yes,
have
Yama, you
just
have
one
any more comment? Yes, please.
One minute
Quickly.
question for Dr. Tariq. Would you recommend, sir, using dexmedetomidine as an opioid sparing and anesthetic sparing that would offer her some anxiolysis, some bradycardia during anesthesia or not?
Look, what I usually give in cesarean section, if the patient is doing, I mean, I don't give midazolam. I don't give anything like that. If I want to sedate the patient prior admission to the OR, I just give a tiny dose of propofol. 30 milligrams of propofol given on her transfer to the OR would do the job of midazolam with no bad effects. Number two, give her good analgesia. I mean, if you want to give her morphine, why not to give her morphine? How much?
You give her medicine, yes.
How much? I mean, what was her weight? Was she obese? Was she normal?
I don't have the exact weight in her charts, but she wasn't obese. No, she was tall and slender.
75, 80 kilograms?
Like this, yes.
Yeah, 10 milligrams of morphine, but bear in mind that morphine has to be given very early.